Me great pleasure to introduce the next speaker, Dr. Nisha Nigil. She completed her MBBS from Trivandrum Medical College and endocrinology training from SGPGI Lucknow. After doing her clinical research fellowship and master's in clinical epidemiology from University of Toronto, Canada, she now practices as an internist and an endocrinologist in Sudbury, Ontario. She is the assistant professor at Northern Ontario School of Medicine and has won several research awards, including a Young Investigator Award from Endocrine Society USA. She's also the recipient of the prestigious PSI Foundation Knowledge Translation Fellowship. And we all know Dr. Nisha Nigil as the president of AKMG Canada and also serves as the membership committee lead of AKMG. She will be speaking about a talk that's considered timely in the era of fake news and false information. The topic is trial and error, evidence-based medicine during a pandemic. So I shall invite Dr. Nisha Nigil Haroon to speak on this topic now.
Will be to review the history of evidence-based medicine with the intention of improving our understanding of this whole phenomenon. We all know so much about it, but I guess it's very important to revisit this concept due to the evolving nuances around the scientific research happening in this field. And we're going to revisit the trials. I know Dr. Hari briefly outlined the various trials, but I will be focusing on the pitfalls associated with the trials. Moving on to the actual presentation to give a little bit of background on EBM. So we all see that most of the research papers or scientific publications end with a statement saying that more research is needed to conclusively establish the finding. I guess nowhere in the history of medicine that this statement has become increasingly important. We are seeing a tsunami of coronavirus-related research publications. And I guess it's very, very important to carefully examine and interpret the evidence that is coming out of this pandemic. One of the most trusted resources in evidence-based medicine is Cochrane. And they have live systematic reviews. Even many other journals and resources in the United States do publish live updates and live systematic reviews on emerging evidence in various aspects of the pandemic. So these are some of the snippets that I captured from the Cochrane UK website today. They're always trying to clear misconception about the anecdotal evidence, what not to believe, what not to follow, things like that. The various aspects of COVID misinformation are being covered by Cochrane experts on a daily basis. So this is where all this started, right? The whole evolution of evidence-based medicine. So it does not to remember episodes from history promoting immune boosters, fake remedies, and fad diets, things like that. But the fake remedies continue to affect the way evidence is evolving and in the way our practice is changing. So politicians and monarchy promoting these sort of things to the public. Again, this is all based on the premise that absence is evidence is not evidence of absence, right? It's it is very important to understand this concept or common argument for using unintended. Think that we must do something, right, to promote or generate, even without in the absence of evidence, something, or what's wrong with using something that's mild or something that is not meant to cause any harm. But I think we as physicians, we have to engage in, if we start engaging in such practices, we'll be faced with attribution bias. So that means, there'll be a relative selective observation of, we think that these false benefits are attributed to the medicine that we actually use. So we've seen many examples during many experts in the field arguing against the full approval of remdesivir because it hasn't been shown to lower mortality. So some experts argue that this might lead to indication creep. For example, this is only shown in clinical trials to work in a limited set of and also for patients who have been hospitalized. So the problem is that with FDA approval, this treatment is likely to be used widely and adding on to costs and ineffective, or even other circumstances where the disease is mild. Or the medication might be used early on during the disease course. So there are also so many controversies around this aspect that need to be clarified to us as physicians. So now coming to the history of evidence-based medicine, as I mentioned, the whole concept was developed by a scientist and nephrologist, Dr. David Sackett from McMaster University in the early 1960s. And prior to that, we were basing our clinical recommendations on anecdote, and this 1600s, we're basing on personal journals and textbooks as anecdotal evidence, and then came the peer-reviewed journals, and now this is all being triggered by internet. So this is where the definition was derived in 1992, again by experts from McMaster University. Dr. Gordon Guyatt is considered as the father of evidence-based medicine. This concept was evolved as part of the residency training at McMaster University for general internal medicine. Later, he derived the term called evidence-based medicine, which became the core of the residency curriculum. So I just wanted to share couple of slides on Dr. David Sackett. This man has an interesting personality, apart from his medicine. So he was a nephrologist, and then he went on to become a clinical trialist. Then in the third phase of his career, he became a critical appraiser of strategies. So he went into, towards teaching evidence-based medicine, but he quit this part of his career at the age of 49. And he even had a phase during which he did his residency in hospital internal medicine. So he thought, he had lost his clinical skills. And he's very famously known to have said that, after 10 years of being an expert, you should stop. We just listened to all our experts here. And Dr. Sackett thinks that because your visa given too much weight and get in the way of new thinking. So previously, apparently he was an expert of compliance. And then in 1980, he stopped work on compliance. And then he moved, and his last lecture, very interestingly, on EBM was in Poland. And he stopped lecturing on EBM after 1999. So what is evidence-based medicine? So, from a philosophical aspect, what is the purpose of medicine? So we discussed public health research. So that is what is going to advance the field. So I'm not going to the actual definition. It's available everywhere. But there is a standard definition for evidence-based medicine. So it is based on the core principles that there is combination of synthesis of individual expertise with external evidence. So we still have to depend on individual expertise, but the actual evidence is synthesized based on systematic research. So sort of de-emphasizes memorization. And then most importantly, or interestingly, this disregards the concept of authoritarian expert opinions, right? We are not basing our judgment or treatment decisions based on one person's opinion. This is a collective force, a collective attempt to generate evidence. And now the principle is heavily dependent on medical informatics and online resources, including Cochrane, which I just outlined. Why do we need evidence-based medicine? In the United States, we know the healthcare spending is huge. And so even in Canada, we spend a lot of our healthcare taxpayer dollars in healthcare. We have a single payer system. So it is increasingly important to cut down on healthcare costs by using evidence-based diagnostic and therapies. So this is where the whole premise of evidence-based medicine is coming from, and also ineffective treatment with potential harm, right? So, and with new therapy and research and technology, the cost is increasingly going up. And I think with the fee-for-service model that we are all part of, that we are rewarded for providing more care, right? By doing more investigations and more treatment and aggressive measures. So at the end of the day, we always wonder whether higher spending is promoting better healthcare or quality. So this is where we need evidence. Why do we need evidence? Again, we could be facing poor quality care. We need research to compare the effectiveness, cost, patient preference. And the patients at the end of the day are the stakeholders. And so we need to listen to them, right? And are we able to translate all this emerging knowledge into practice? So in the face of this pandemic, we really have to disregard the old concepts of expert-based medicine, evidence-based medicine, opinion-based medicine. And it is interesting to note that many of us still are easily swayed by anecdotes and propaganda. and probably very susceptible to confirmation bias. So I'm not going into details about the psychological aspects of various bias that we are subjected to. So coming back to the concept of evidence-based medicine, previously we thought it was only applicable to our clinical practice, but now it is affecting our own health, our own personal protection. So we need more evidence as to what type of PPE we should be using during a pandemic. Now, what happened to the EBM during the pandemic? What did we see? Really distorted and misappropriate use of evidence-based medicine. We saw a torrent of positive observational studies, tsunami of anecdotes. There was too much emotion, too much emergency, too little evidence, and a counter-revolution with possibly unacceptable consequences. So we are living through it now. So this is what we saw, right? All those dismissed concepts of medicine coming back. Authority-based medicine, faith-based medicines, where you believe that things work even though there's no evidence for it. Politician-based medicine, hope-based medicine, and of course, finance-based medicine, probably driven by markets. So end results, we are still finding that a high amount of GDP or proportion of GDP is devoted to healthcare. We're seeing spurious trials, spurious meta-analysis, conflicting guidelines. And in general, we think that 85% of biomedical research is an absolute waste of resources. So is there still a place for rational thinking and evidence to help humans? In the face of COVID-19 pandemic, we saw a lot of observational data emerging from different sources globally. And we do know now that more than 60,000 COVID publications have been listed. And it is very, very important to remember that observational data is affected by residual confounding. And we do see that the data and protocols are not shared. Many of these studies don't have any pre-specified protocols and analysis. Also remember that causation is not proved by association. And we need to remember that the choice of therapy should always rely on the best possible evidence emerging out of good, high-quality randomized controlled trials. So science should be about evidence and its cautious interpretation. So the interpretation should be left to experts and people who are dealing with trials and this sort of evidence on a day-to-day basis. So there are some important differences between so what we need is well-designed and well-conducted RCTs. We don't want independent RCTs, and we don't want methodologically weak RCTs. There's poor evidence, poor quality RCTs being published, even in high-impact journals. Unfortunately, we don't want observational studies. And again, we have to be very, very careful about preprints. So coming to the global clinical trend milieu of COVID-19 pandemic, so there was a study recently published looking at the first 100 days of COVID-19 research. So apparently nearly 700 trials have been registered, targeting nearly 400,000 patients globally. And most of these studies have been registered from China, some of it from United States. And this is data from July, so I'm sure there are more studies being registered. And most of these studies, 75% of these trials are being conducted in hospitalized patients. Interestingly, only 4% of trials are being done on healthcare workers, sadly. So mostly in antivirals, antimalarials, etc. And these, I will not go into the details. These are the number of trials being added every week. And if you look at the response in the first 100 days, apparently are expected to be completed in 2020. But I highly doubt that only treatment, all these trials are going to be completed by end of this year. I very much doubt the successful completion of most of these trials. And apparently their full enrollment. So enrollment in clinical trials is a challenge during a pandemic. And these are some of the trials going on in hydroxychloroquine. There are still trials ongoing, numerous trials going on, wasting precious healthcare resources. And interestingly, even the study protocols are being published. I did a PubMed search today looking for hydroxychloroquine trial results. I found 18 results. I think most of them were study protocols being submitted. We're still waiting for hydroxychloroquine trial. I mean, we have had landmark studies disproving the benefit, but the rest of the 170 trials have disappeared. Same thing is happening with remdesivir. We do have, as Dr. Hari discussed today, we do have clear data, process math in steroids and plasma. So we did that. The trials are ongoing, but enrollment is an issue here. So probably we have to think about these trials as a potential waste of participants and investigate time. So we have to make good use of our resources and focus on avoiding more harms than benefits. So I'll not go into the details in the interest of time. And the vaccine trials, we expect 5 trials to be completed in 2020, 5 to be completed in 2021, and more to be completed between 2022 and 24. And I'm going to skip, so a couple of trial slides on EBM pitfalls. There is a lot of pressure for people working in the academic area. You're fighting for authorship, and there's all this power game networking going on, and there's immense pressure on these researchers to publish. And again, what we are going to see is a tsunami of trials with small sample size and varied heterogeneity in design. And we are finding that the volume of evidence or guidelines is unmanageable, and we don't know if the statistical significance is relevant for clinical significance. So that's going to be another issue. We might see small trials with small proven effects, less number of events. So those are all pitfalls. What we need to see ideally is that properly conducted large-scale multinational trials, 1 or 2 good trials, and this will improve the publishing standards and also integrate EBM into medical education. So, and we need to see multiple levels of evidence, and we have to make sure that the research is unbiased. And we need more transparency. For example, in the vaccine trial, we need more transparency. This will create more confidence in the public. So this is a very important slide. When you're interpreting evidence, make sure that you first read the methodology part and also the results, and make sure that beware of large effects in trials with small number of events, and also beware of faulty comparators, beware of small effects and extrapolation to low-risk patients, and beware of uneven emphasis on benefits and harms. So, and there are various methodologies to grade the evidence. Always base your opinion based on the quality of evidence. There are scales that are being validated in many ways. And what we need to see is double-blind, randomized, placebo-controlled trial based on the core ethical and scientific principles of trial content. There are guidelines already in place and working, so we need to have trust in the system. And there are different adaptive trial designs being validated by clinical trialists in the COVID field. But another important aspect of this evidence-based medicine is that other areas of clinical research is being neglected. For example, TB or HIV or malaria. This is going to cause another pandemic. So again, that's one area that needs attention. And this was one example of a large randomized controlled trial, very successfully conducted and published. And generally, we all are now familiarized with the trial. This trial included 172 recruiting sites. So it is possible to do high quality, large scale randomized controlled trial even during a pandemic. And these are the other trials going on. So we have the Solidarity trial, which is run by the WHO, which has 4 arms. And then this is exactly the background of evidence-based process. And if you look at the playbook of evidence-based medicine in 2020, we should have full faith in high quality peer review. Watch for retractions. So far, 35 articles have been retracted. We also saw the scandal of a major journal article being retracted from Lancet and New England Journal. We have to base on quality over quantity. And another important aspect is knowledge translation and public and stakeholder engagement during a pandemic. And also don't forget the potential of social media landscape. And then again, a lot of this is affected by conspiracy theories. We do have to keep in mind that the reason for misinformation is usually stemmed by political agenda. Sometimes it's bad science, poor evidence, information overload. And as I mentioned, I think more importantly, what we now see is poor stakeholder engagement, whether it's public or other people who are at the receiving end of these interventions. So again, so I'm going to skip a couple of slides in the interest of time, and I will outline some of evidence-based resources. There are numerous resources available now through American College of Physicians, Cochrane, and UK-based institutions. So to conclude, so this battle is humanity versus virus. It's not Democrats versus Republicans or economy versus public health. So we need evidence and experience to prevail. So this is dogma. We don't think the natural is best. We've always done it that way. And also conventional thinking that we always think that everyone does it this way. No, this has to change. We need evidence, evidence-based, and evidence supports the way. So in conclusion, we need evidence-based medicine beyond all other aspects of evidence that we see now. I think we all should be part of the army of healthcare and policy experts that defeat the pandemic. I'll thank Nigel for the wildlife photography and, more importantly, AKMG education community and our president, Dr. Subramanya Bhatt.